Okay, and so he's going to be talking to us about managing your medications and also deprescribing certain medications if it causes you any harm. But he will go more into that in his presentation. I will go ahead and turn it over to him here, and he will tell you about himself and his organization.
Yes, hello, everyone. Thank you so much, Kiana, for having me on board. It's a pleasure to be here in front of you all here with the Parkinson's Association of Carolinas. As mentioned, my name is Dr. DeLon Canterbury. I am a board-certified geriatric pharmacist, as well as the founder of Geriatrics. So we are a telehealth-based deprescribing company that focuses on reducing the pill burden in our seniors. So we focus on not only talking about holistic and healthy ways to get people off of prescriptions, but we try to find other alternatives to make life easy for the caregiver and the patient while reducing unnecessary side effects. And sometimes they can even be fatal. So today we'll be managing and discussing some of the tips I've shared and seen in the world of Parkinson's disease and how you all can start thinking about ways to use your care team, especially your pharmacist, to weed out any potential problematic medications. So let's get started. So as mentioned, this is really intended for education and wellness purposes. So any information here, again, you would want to discuss with your doctor before you go about having a conversation or considering to act on this information. So what is geriatrics? Why am I here today? Honestly, we have an aging population that is thrown tons of medications, and we don't always know if this is the best for them at all times. And so what geriatrics does is help your providers, your prescribers, and your families really sift through whether these medications are actually necessary or not. We do this all virtually. I'm based in Durham, North Carolina, but we help patients all over the country and the world. And so we focus on providing a concierge, personalized approach to medication deprescribing. And deprescribing, for those who may not know, is the safe removal or reduction of prescriptions under the supervision of a trained medical provider. Okay. So we do this as a part of a care team, all with the intent of reducing any drug interactions, unnecessary or preventable side effects, falls, and of course, making sure that our loved ones are living gracefully at home, right? So some of you, may have seen me before. I've been featured here with you all, gave a talk a couple years ago, but I've done a lot of work in the COVID space. And so I have served as a member of the African American COVID Task Force based in Durham, which was really focusing on vaccine equity and addressing some of the misinformation we saw in the beginning of the pandemic. So my role there as a pharmacist was really to kind of discuss what all are in those vaccines. And that career or my role there has leveraged myself to be on a number of news features and platforms from WRAL to PBS, where we discuss the elder housing crisis and, of course, the need to address overprescribing with the opioid epidemic, along with our roles on Spectrum News and CBS 17. So all of this had started in 2020 when I founded Geriatrics. So who am I? What brings me here today? So I got to start with everything with my family, of course. I'm the oldest of three. That's my mom, Sandra, and my dad, Stanley Canterbury. And I'm the oldest of my brother, Devon, and my little sister, Dacia. And they emigrated to this country in the early 80s to Brooklyn, New York. So my parents came from South America. They are Guyanese, or from Guyana. It's the only English-speaking country in South America that my parents hail from. And so a lot of my cultural upbringing involved their approach to medicine, right? My parents were all about what can we do naturally, what herb or tincture can we brew to help with your cold or help with your asthma. And so I grew up exposed to all types of natural remedies that honestly, my mom was kind of spearheading in our family. And so me, to believe it or not, I was a bit of the awkward duckling as a kid, was always pretty shy and knew I had a loving heart for people, but didn't really know how to communicate that, right? But we ended up leaving New York in '96 to one avoid the crack epidemic in Brooklyn, but also to have a better up living for us, as immigrants. So we moved to a suburb of Atlanta around Marietta, Cobb County, Powder Springs, and grew up there. And now I came here to the Carolinas in 2010 to pursue my career in pharmacy school. And so after graduating from pharmacy school from UNC, the number one pharmacy school, Go Heels, in 2014, I ended up working as a community pharmacist. I was a pharmacy manager in Henderson, North Carolina for about 2.5 years, then moved back to Durham and then floated around the state from Greenville to Greensboro, you name it. I pretty much worked anywhere. But honestly, I got a bit burned out after seeing the way healthcare was delivered in our community pharmacies, especially when it comes to our aging citizens. I felt I didn't really have the time to give that care and full attention that you can't always get in some of your community settings. You were thrown with giving a bunch of vaccines, right? COVID hit. That was basically a big service we had to provide and dedicate our time to. And so a lot of the holistic patient care that I love to give and thrive on, I couldn't really do in this setting. And so I got a bit angry with the system, with the health system, with seeing so many drug interactions that were preventable, particularly in patients that were over 60. And it's even worse if you are, of an underrepresented group or minority population. But truthfully, I got a bit depressed with this whole way of delivering care. It was basically clock in, clock out, make sure everyone's pills match their name, but there wasn't any approach on when do we stop giving these pills? When do we look for other alternatives? How can we provide the patients with tools to get them off of harmful meds? And so I got depressed and I got angry and felt there had to be a better way. And so, truthfully, in this stage, I was a bit of a passenger in my own life. I just really didn't vibe with the way pharmacy was going. And I felt we as pharmacists can do so, so much more with our intellect and our drug knowledge to really advocate for people on a new level. And if you didn't know, overprescribing or inappropriate medication use is a public health pandemic right now. The World Health Organization ranks it as one of the top 10 threats to humanity, and it's inappropriate medication use. And that's where I decided to create Geriatrics to focus on giving people that peace of mind. You may not always know, like, should I send my mom to a nursing home? Is it the meds or is it her disease state? That's what we're able to help figure out for people who aren't sure what to do next. And so after my, depression and anger with the system, I decided in 2020 to step down from my pharmacy manager role and start hitting the ground running with geriatrics. And so I started not only working with my business, but I started volunteering in the community. I got more involved with the COVID task force, joined Senior Pharmacist, which is a nonprofit that helps seniors figure out the best Medicare plan. And I started volunteering with Community Health Coalition and serving as a poison control pharmacist. And so one thing I want to make sure you all are aware of, there are pharmacists that do more than just put your name on a pill bottle. There are tons of us leaving the traditional model and starting our own businesses, consulting for families, consulting for businesses, educating people. And so what I provide for my patients is genetic testing to make sure that the medications they're on are safe for their body, not just assuming everyone responds the same, which our traditional medicine does. We do full medication reviews. So we're looking for opportunities to get you off of those pills and consolidate and save costs along the way. We create personalized deprescribing action plans. So we work with families between a month or 3 months to figure out the best action for them, all while looking for ways to do things with their providers and reduce, falls, risks, all over telehealth. So we can all do this from the power of Zoom. Where COVID has a lot of us getting used to this type of model, and that's what I provide for my patients. But I can't lie, our health system is definitely broken. About 275,000 people die each year just from medication side effects and mismanagement. That's 750 seniors that are sent to the hospital each day because the medicine was inappropriately used or dosed. And so all of us are paying this, not just with loved ones being sent to the ER, But in our costs as taxpayers, we're spending about $530 billion on these mismanaged meds. And it's a lot of it is because we're not really using pharmacists the way that we were built to use. And then, of course, you don't know what you don't know. I mean, how many of you had a severe, deep down medication review with your loved one to make sure everything is actually dosed right, or if it's even still appropriate, or if you maybe even had a side effect where you're able to comfortably discuss that with your provider? That's the power that pharmacists have. And so, why I bring up my grandma is because she unfortunately was another statistic here. She was given an inappropriate antipsychotic for her dementia, her mild dementia, while she was in a nursing home. And that led to more confusion, more wandering, lethargy, just being irritable, and trying to escape the house. And all of this led to her being eventually kicked out of the nursing home because she was unmanageable from her worsening behavior symptoms related to her dementia. Because of this, my parents had to move her down from Brooklyn to Georgia and figure out how, as full-time parents, to take care of her, put their 3 kids through college. And it was a bit of an expense and an energetic drain because it was thinking, here we are doing everything we right, but our mom or grandma wasn't just getting the best care. But it took a Rite Aid pharmacist, a community pharmacist, to really just stand in question and say, hey, do we really still need this? She took the time to call the doctor, got her safely tapered off that medicine, and her symptoms of dementia essentially went back to their baseline self. So again, guys, we got to do better. And I think a lot of it is asking the right questions. Got to leverage your pharmacist, sure, but don't always just assume every medication is the best thing for your loved one. And that's what we'll be discussing today. And so we focus as Deprescribing pharmacists to educate other facilities, other patients on how to really save money, but more importantly, how to reduce that harm, reduce those falls from happening, reduce the risk of polypharmacy, which is the use of multiple meds, and then communicate those barriers in care and what's really best by improving quality of life with med management. So let's dive into what we'll discuss today. We're going to describe a bit more on what medications are used as standard therapies to help with Parkinson's. We'll even understand some of the risks and benefits of which therapies may help versus another and in what stage. And then we'll look at some potentially inappropriate medications that you want to avoid when it comes to Parkinson's disease, while outlining some tips and tricks for you to use as it comes to medication management. So most of you already have a pretty good understanding what Parkinson's disease is, but it does involve the breakdown of nerves within the brain, all right? Usually right in the middle of our brains, there's an area that relies on the uptake of a chemical, a signal in the brain called dopamine. And so in Parkinson's, it's suspected that there isn't enough dopamine or signalers in the brain for us to respond and, of course, have those movement issues and other motor and non-motor symptoms that we see as it relates to this. And so Parkinson's disease used to be estimated to have about 60,000 people each year diagnosed. Now it has increased to 90,000 guys. So that is a 50% increase of the previous estimate of Parkinson's disease in the US. And yeah, that is enough to fill the Rose Bowl Stadium. And Parkinson's disease is the second most frequent age-related neurodegenerative disease, affecting about 10 million people worldwide. So this spells opportunity for us as clinicians and providers to be aware of what's around the corner. We have more people being diagnosed with this. We have to look at more holistic and interdisciplinary models to approach and manage these patients adequately. So some of the hallmark signs we may notice with Parkinson's disease are issues with walking, gait, muscle rigidity, tremors, and sometimes slowed movement, all right? And so there are indeed stages of Parkinson's disease. Stage 1, you may have some mild symptoms, but you're still able to carry on your day-to-day activities. Generally in this stage, we are looking to kind of delay the use of certain medications until it's absolutely affecting their lifestyle, their quality of life, their day-to-day doings. And so most of you may be familiar with the medication levodopa carbidopa. That is essentially the workhorse of Parkinson's disease therapies. But I have to make sure you all are aware that everyone with Parkinson's disease isn't going to be the same as everyone with Parkinson's disease. Every single person is going to identify differently and may present differently. And so you have to individualize our treatment plan as well as other factors in the patient's care before assuming they're all about to be the same. So we got about 1 million Americans in total that are suffering from Parkinson's disease. Hispanic and white ethnicities are the most affected. And our males has about a 50% higher risk of developing Parkinson's disease as compared to our females. Parkinson's disease itself is not fatal, but it can severely impact quality of life, as a lot of you as caregivers or those who may have it actually may know. And it is, of course, associated, as I mentioned, with the loss of nerve cells in the brain that make dopamine. And dopamine is our pleasure hormone, our feel-good transmitter. And so it gives us pleasure when we eat, when we enjoy company, when we feel love. Those are the dopamine signals going on in our brain. And so a lot of the drugs and therapy that manage Parkinson's try to mimic dopamine in the body. And so with some of the stages, at stage 2, as you progress, you're going to see a little bit more of some of the tremors and some of the stiffness beginning in those muscles. Stage 3, you may start seeing slowing in the movement and loss of balance. And so, of course, Parkinson's disease may put people at risk for walking disorders, right? Gait disorders, imbalance, falls, all things we want to be careful of. 4 and 5 are the more severe ends of the stages of the disease, where 5, essentially walking or standing is pretty much impossible, and they may be confined to a bed or a wheelchair. So, as mentioned, 90,000 people have or are diagnosed newly with Parkinson's each year, with age being the ultimate risk factor for getting Parkinson's disease. I want to make sure we just had a picture that kind of shows what some patients may look like as it comes to the movement, the stoop posture. Sometimes you'll see those tremors in the legs, and some of you may have loved ones that have tremors, restless leg syndrome in the middle of the night. And so that can keep them up, and that can be very disturbing for the spouse who may be with their loved one with Parkinson's, or of course for the patient themselves. Now, this all in all can lead to an increased caregiver burden, right? We know caregivers are the ones who are unpaid providers in our health system. They are spending almost a day each week unpaid managing the care of their loved ones, and even more, of course, for those living with them. And so there is a burden, and these patients tend to have a higher risk of being put into a nursing home. And this can, of course, can affect the quality of life for both caregiver and our families. So there are also some non-movement symptoms that we should discuss associated with Parkinson's disease. Some of my patients, particularly, I generally see a good bit of fatigue, a lot of naps, and of course, depression and anxiety. There are, of course, other forms of Parkinson's or some presentations of psychosis, which is essentially, feeling delirium, acting out of it, just having a change of mind and cognition that can lead to, in a way, some irrational behaviors. Now, in terms of some of the earlier signs of what we may see with lack of movement, you may have some other signs of constipation, some stomach upset. You may have some sleep problems, like I mentioned, associated with restless leg syndrome. And then you may have a loss of sense of smell or even drooling. Now, generally with people, when it comes to motor movement disorders, you're going to want to make sure they have some type of cane or walker to help with that. There may be tremors in the hand and feet. There may be some muscle stiffness, blinking less often than usual, and there may be some trouble swallowing, which can also be an issue for the quality of food and, of course, nutrition. And, of course, there may be unstable posture or gesture while walking. And so all of these can contribute to a poor quality of life and can lead to morbidity and mortality. Not to mention, I also want to mention that pain can definitely be associated here. And sometimes patients just cannot express that they may be in pain. So generally, pain is underreported in our seniors, but even more so with those with cognitive impairment. So we want to make sure we're ruling out all we can to address pain if that may be a cause. And even pain can be associated with anxiety, depression, poor sleep quality, and worsening dementia. So that's something to also note. And I can't lie, the clinical picture from the prescriber end can be quite difficult. We're in between a rock and a hard place here. Some of these medicines have been out for decades, and we've got a couple new ones on the market, but we do have some good efficacy, but nothing to date has been shown to reverse or cure Parkinson's disease. And so we do have some good workhorses, some good drugs that can do the job and maintain quality of life as best as possible. Um, but there needs to be a fine balance between some of the side effects, the risk and pros and cons of being on certain medications versus another, and of course, understanding the timeline as the progression of the disease may take place. And so one thing that I have to make sure we're aware of, and particularly those with cognitive impairment, is the prescribing cascade. And so this is one of the biggest concerns I see whenever I'm doing a medication list and I may see 20 or 30 pills and I'm wondering what the heck is going on, right? So in a prescribing cascade, a patient may have one medication being used to say treat high blood pressure. And that high blood pressure medication may sometimes cause a side effect. And say in this instance, it's a matter of causing more fluids collection. Instead of that side effect being seen as a side effect, it's perceived to be a whole new health condition. And when this happens, a new prescription may be written to treat that health condition instead of actually addressing it as a side effect and just managing that first drug. And so when this happens, another drug is added on board. So we have drug B. And now we're trying to treat that fluid collection, but now drug B is causing another side effect, say overactive bladder, which in our Parkinson's patients, we do have issues with incontinence and GI upset. And so again, and so on and so on, this cycle continues. And I can't express how the importance of being able to identify this can honestly reduce harm, it can reduce risk, and honestly just make life a little bit easier in terms of the pill burden associated and even the costs as it comes to maintaining that quality of life. So I always want to make sure that when we're doing a med review, we're looking for any potential prescribing cascades, essentially this ripple effect of drugs treating drug side effects and other side effects and so on and so on. And this is where your pharmacist is best equipped to figure this out for you. I've also used the word polypharmacy earlier. And so polypharmacy is essentially the use of five or more medications. Sometimes it may be written from multiple different providers. It may be a patient going to multiple pharmacies and the pharmacies aren't talking to each other. So we're not getting a full picture of the med list. And of course, people who have multiple chronic health conditions tend to have a higher risk of having polypharmacy. But polypharmacy is the technical definition of five or more. Of course, we want to make sure when I do med reviews, and this is a question I implore you to ask, is every time you go to a visit for your doctor, or even in your chart, if you want to send a message, find a way to ask if your loved one is on several meds, what can we do to reduce this medication list at every visit? Okay. Don't just do it once a year. Do this as much as you possibly can. Have an open dialogue about whether some of these are actually still worth the benefit or the risk may outweigh those benefits. Have those open discussions. Not every medication has to be in your body for the rest of your life, okay? And one way I try to assess that is when you go through your med list, you want to make sure it's completely up to date. You want to make sure it's accurate. You want to make sure you're including all over the counter prescriptions, all herbal supplements, all vitamins, and make sure it's up to date, of course. And then finally, you want to really just ask, are these medications saving my life? And are they vital or are they important for my quality of life? Are they helping me live better? If they don't fall under those two categories, it may be worth discussing an opportunity to deprescribe or safely consider getting weaned off of some of those medications. All right. And so I harp a lot on inappropriate antipsychotic use, not just because my grandmother suffered from this issue, but it's a growing problem within our dementia communities. There is a more appropriate role for antipsychotics within Parkinson's behavioral disorders. But in this example here, I'm specifically speaking to dementia, which is seen in nursing homes. And so with dementia, the use of these drugs are actually inappropriate and have been shown to increase the risk of death, stroke and heart attack, and even infections. And so if you have a loved one who may just have dementia and not necessarily Parkinson's, it's important to note that the use of drugs like Seroquel or Abilify may not be appropriate for them. And if they are to be used, they should be used for a very short time. Again, I want to preface that this is particularly for dementia, not exactly for patients that have Parkinson's. There's a different set of drugs you can use for that. So let's dive into some of the meds. What are really the goals of therapy as it comes to our treatment plans? Really, we're here to control those symptoms of Parkinson's as long as possible, right? We want to make sure that people are moving as safely as they can. We want to reduce any drug side effects. We're looking to really improve that quality of life. And of course, we want to prolong those on and off periods, those on periods particularly, as much as possible to ensure that our patients are well managed, all right? And so the workhorse of Parkinson's disease is carbidopa levodopa. And so, as I mentioned, with Parkinson's disease, we don't have enough dopamine in the body. And so this medication, the combo of two different drugs, is intended to mimic or look like dopamine in the body. This is again is the mainstay of Parkinson's disorder medications, and it gives the brain straight up just dopamine. It's really most effective for controlling some of those motor symptoms that we see, those movement symptoms, the muscle rigidity, the tremor, and slowed movement in early stages of Parkinson's. Generally, it's used alone or it's used in combination with other classes of medications to help manage this. There are a couple of side effects, but this is one of the most effective and well-tolerated medications out there. Now, I'm sure a lot of you have dealt with this, but sometimes the dosing of this medication can be critical to dictating whether that on cycle or off cycle will take place. Sometimes there are formulations of this drug where you can may have it as an extended release form. This comes as the brand Cinnamon. Sometimes they have gel forms. Sometimes they have forms that you can get directly as a patch. And we'll discuss some of those later options as well. So carbidopa levodopa is usually the mainstay. You can use it alone or you can use it with other drugs. However, it doesn't last too long in the body. It lasts close to about 40 minutes to 100 minutes in the body. And so half-life I have listed here essentially is saying how much time does it take for the medication after you take a pill to be reduced to half the dose in the body. And so if it's only going to last you about an hour and a half at most, that is why you're seeing it dose about 3 or 4 times a day for people. It just doesn't last that long. In fact, levodopa, if it were given alone, only 1% of that dose would be absorbed. That is why it has to be combined with carbidopa, which is meant to extend how long the medication works in the body. And even with that, it still only lasts about an hour and a half. So that's about why we are having to dose it so frequently throughout the day. All right. So I mentioned this is the workhorse, but it does have some side effects. The most common ones we will see are going to be stomach related, right? So some nausea, some headache can occur, as well as some back pain, vomiting, and in some instances, insomnia. Even at higher doses, you may even start seeing some overworking of muscle movement and agitation. So it can cause what are called dyskinesias, basically involuntary movements that can't be controlled. And that can be seen with higher doses and continued use of this medication. Now, as much as carbidopa, levodopa is used, the effect of it isn't going to be lifelong. The best effects generally happen within the beginning stages of use. But about after 6 years of using the medication, unfortunately, some of the management we saw in managing those movements can be reduced. And so you end up continuously having to increase the dose or even increase the frequency to get that same effect. And so after a couple of years of using this, the impact kind of just plateaus after a while. And that's where we start considering the use of adding on other therapies to make sure that carbidopa levodopa is still doing the best it can. So yes, about 40% of patients will get that return of motor dysfunction after 4 to 6 years of using this. Another class of medications that are commonly seen are dopamine agonists. And agonists basically mean they mimic what the dopamine structure looks like. And so I have a picture here that kind of shows you how structurally, how dopamine on the top left looks and how some of these other drugs look pretty similarly in terms of the shape and structure. And so they're meant to literally mimic dopamine in the body and help as a form of therapy. So dopamine agonists are really awesome in the early stages of Parkinson's disease. You will have drugs out there like Requip or Ropinirole, Pramipexole or Mirapex, or Nupro, which is a patch rodigodine. And so with these, they're really great to be an add-on therapy for carbidopa levodopa. All right. These act directly in that central part of our brain, working on dopamine receptors. So it basically goes to that site and says, hey, I'm here, dopamine's here, start working. And it actually helps to maintain and prolong those on periods and reduce those off periods. And so dopamine like agonists like Requip or Mirapex are pretty awesome early on. Okay. They can be used as monotherapy or alone, or they can be used as an add-on to carbidopa levodopa. In fact, we're starting to see more prescribers switch to using this as a first-line agent for those with early Parkinson's disease before putting them on the carbidopa levodopa, mainly because these are just really good and they last longer in the body. And so they're really good at managing those early signs and motor symptoms. And so before they pull the trigger on carbidopa levodopa, they'd rather use these a bit more. But these do tend to have a bit more side effects. So that's another point I want to make. They can cause particularly a good bit of sedation and at times insomnia. It can cause, of course, the usual stomach upset, so nausea, some dizziness and vomiting, as well as constipation. But generally, the sedation are some of the main side effects I see, along with some of the other headaches as well. There's another class out there that has another added effect when used with carbidopa levodopa. And so this medication are called catechol O methyltransferase inhibitors. Doesn't really matter the technical name, but what they do is they prevent the breakdown of dopamine or even carbidopa levodopa within the body. These are also pretty well, but unfortunately, when they first came out, they were a bit expensive. Actually, one of our first patients had Parkinson's disease, and he was on entacapone, and I tell you, it was quite expensive, close to $100 a month. One of the best things we were able to do for them was to get him enrolled into a clinical trial. And so instead of him paying $100 a month, we were able to get that medication completely covered for free for them, and he had some better resolution of his Parkinson's symptoms without having to come grossly out of pocket. And a lot of our seniors are on fixed income. So again, that's some of the powerful things pharmacists like myself can do is to figure out ways to make drugs extremely affordable and exhaust everything we can in our community for our patients. And that's what a concierge pharmacist can do for you. And so these class of drugs, particularly brand names are known as Comtan or Tasmar, they can reduce the off period by about 40%. That's pretty significant. And increase the on period by about 25%. And so because these medications technically reduce the breakdown of dopamine, we can, in theory, reduce the dosing for carbidopa levodopa. And so you will see some providers back off on the higher dosings for carbidopa levodopa because of the medications here. So that's one of their roles. Tasmar, which is also known as tolcapone, um, is a bit more potent than Comtan, but also has more side effects. And so it has a higher risk of having liver toxicities or liver enzyme dysregulation. And so some of their side effects are diarrhea, nausea, low blood pressure when you're rising. So sometimes getting up too fast can cause a sudden drop, and that can lead to falls or dizziness or fainting. But also, the vivid dreams can also occur with the use of these medications. So something to also be aware of when you see this. Now, there's another class of drugs that can also be considered, selegiline and razagiline. They also can be used in combination with levodopa and are pretty well tolerated for most people across the board. They're also significant at helping with reducing some of those motor dysfunctions. Um, and selegiline, particularly, has also been shown to reduce the use or the need for levodopa in the beginning stages by at least 9 months of using this medicine. So this is before someone's on carbidopa levodopa. Sometimes using this can prolong the need for those other types of meds. And I want to make sure I just highlighted that there are several different classes of medicines out here that are pretended to treat Parkinson's disease. I will say the mainstay are the dopaminergics, so basically drugs that mimic dopamine, um, as well as, whoops, as well as, of course, some other classes of drugs like the selegiline and razaligine that we see here. Now, because of the way this medication breaks down some of these other meds, they do have some significant interactions. And I mentioned earlier that a good bit of Parkinson's disease patients may have anxiety or depression. And so this class of drug interacts pretty severely with any type of serotonin drug. So drugs that that are antidepressants, right? These are drugs like sertraline, Zoloft, paroxetine, fluoxetine, if those ring a bell. Those are known as SSRIs, or selective serotonin blockers. Okay. Now, because of that, they can interact with these type of drugs and they can cause what's called serotonin syndrome, which can be fatal. So that's why it's extremely important to look out for any interactions with drugs that look like serotonin. And in some instances, that could be tramadol that looks like serotonin. And that's a pain medicine, right? We want to treat pain, but I have had cases where combining drugs like this with tramadol can lead to serotonin syndrome, which could again be a fatal life-threatening issue. And that also goes for drugs like Demerol, which is an old school opioid, or meperidine. They mimic serotonin. And of course, like I mentioned, antidepressants like Zoloft, sertraline, those are serotonin blockers. And so you cannot use those medications with these type of medications. Anticholinergics have been around for a minute. And so just like dopamine and serotonin, acetylcholine is another one of those chemicals in the brain that signals the body. And so this used to be the older options for patients that had Parkinson's, but these have fallen out of favor and have not been shown to be effective when it comes to Parkinson's or the motor functions related to Parkinson's disease. And so it's really kind of hard to know what's an anticholinergic or not, but the most commonly one we all know is Benadryl, hugely anticholinergic. And so it can actually worsen confusion and agitation and sedation in patients. And so it's important to make sure you're not just using this willy-nilly for people that may have Parkinson's disease as a sleep aid. It would be inappropriate and generally not the safest option to managing that. So I mentioned this because it's not just Benadryl. There's a whole slew of drugs that kind of fall into this category, from antidepressants to incontinence medications to over-the-counters and even muscle relaxers. And I mentioned the Tylenol PM because Benadryl is the PM in Tylenol PM. And so that long word below the acetaminophen is diphenhydramine. So diphenhydramine is Benadryl, guys. And so sometimes we use all these, crazy over-the-counter products. They have 10 different kinds of Advil and 10 different kinds of Tylenol. You got to make sure you're definitely reading the back of that bottle to make sure it's just what you need, and clear that with your pharmacist and let them know the health conditions your loved ones are on to ensure that's the best option, okay? And another sign of looking for anticholinergic toxicity or too much of it can have increased urinary retention, dry mouth, dry eyes, drowsiness, confusion, more constipation. That can all occur. And so when it comes to actually managing the meds out there, there are a number of ways to do this. We're in a new age of technology. And so there are these devices that can automatically load up the 90-day counts of your pills into one machine, and they can time it and give you an alert on your phone if your medications were taken or dispensed. There are tons of companies that are doing this now. That one particularly is called a Hero device. Of course, I have no stake in the game, but they can be helpful in avoiding having you to load up pill boxes all the time. But I will say managing meds is not easy. It's not even easy for clinicians. It's extremely difficult. So it does take a good bit of organization and leveraging clinical experts in your network of providers to make sure that one, you're on the least amount of meds and that they're the best ones for your loved one. You have to make sure we keep track of what all they're taking. So I mentioned automatic pill dispensers, but they also have blister packaging, which we have pictured here in this image, where they separate by day, time, morning, breakfast, and of course, the time of week. Now, you want to make sure you're keeping track of med lists physically and digitally. And I can't lie, guys, the medical records and health systems generally isn't accurate. You have to make sure you are doing your due diligence to come with the most up-to-date dose, the timing that they're taking it. And as they're taking it, look for any changes in their body. Are you seeing any worsening or more sedation with one drug? Are you seeing improvements with the other? What time of day do you see the most improvements? Those are the clues that can help us kind of tweak when to stop meds or even when to taper or even when to increase the dose. And of course, I say all this to say to use your pharmacist. We provide medication reviews for families anywhere in the country. So that's what we can do for you. I got to make sure we avoid certain medications. And that's why I'm segueing to these classes of drugs that are really notorious for worsening falls in elderly, especially those that may have cognitive impairment. And so clonazepam, diazepam, Xanax, or Valium, or Klonopin have been shown to worsen or they can impair cognition. They can impair mobility. And of course, they can worsen driving for those. And so people sometimes inadvertently use this with a glass of wine or a beer or any alcohol can actually lead to a blacking out. It can cause someone to just pass out and go to sleep for a long time. But they'll be up the next day. But however, it's extremely important to note that these should really be avoided in seniors. And if they're using it for sleep, we're going to want to have a conversation around that. Generally, these meds are not ideal for sleeping. There may be some use for clonazepam, which I've seen for Parkinson's patients that may have restless leg syndrome. And that has been shown to help some patients have some better quality of life. But other than that, you do not want to be using this just to sleep, okay? That is considered inappropriate. Another medicine to look out for are ones I actually mentioned earlier, opioids. These generally increase the risk of falls, injuries, fractures, and can worsen cognition. And of course, with opioids combined with benzos, that is a recipe for stopping your lungs and potentially stopping your heart. So this happens a good bit, especially when we're mixing alcohol with opioids and with drugs like clonazepam. That trifecta is a blackout recipe. And it happens, okay? All because they're older does not mean these interactions don't occur. But there is a higher risk of having respiratory failure with that combo, and that could lead to people essentially passing out and dying in their sleep. So really important to try to avoid opioids as much as possible. I also got to make sure that we're not falling for some of the scams out there, guys. Please don't fall for them. There are tons of people saying this will help with memory, this will help with nerve brain regrowth, and etc. Nothing out there really does that. And if it sounds too good to be true, it likely is not true. So don't fall for the scams. Also, just make sure you're aware of what all they're taking over the counter. It's so important. Every medication matters when we're doing a med review, from the eye drops to the medicated shampoo to the lotions to the herbal supplements to your vitamins. Every single thing has to be included. Don't just assume everything natural is safe. And lastly, I do want to make sure that I point out some non-drug therapies that you can consider. And so I mentioned that this has to take a holistic interdisciplinary approach. That is very much true. We got to make sure we're using physical therapy to help them stay strong, to strengthen their core, Tai Chi, yoga, and even dance have shown some wonderful results in patients using this as a form of maintaining their strength. Occupational therapy, people need help with swallowing, making sure we can try to get some cognitive training in there to help with anxiety and depression. And even newer therapies such as deep brain stimulation, where they're sending electronic pulses to parts of the brain, or even electronic therapy, electroconvulsive therapy can be an option for patients as well. So with that, I just want to thank you all for your time and attention and leave the floor open to any questions or thoughts.
And I'll go ahead and add at this point, you do not have to type your questions in the chat box. Feel free to come off mute to ask your questions.
I have a question about being in later stages of Parkinson's, what the best meds are for that.
Yeah, that's a great question. There really isn't a good answer for that. We're kind of tailoring things to what essentially works best for the patient. And so at this stage, despite the fact that we don't even have the best evidence for late stage, we're kind of just using whatever's all there. And so there really isn't any trials to date that compares what's best for what. We have tons of good stuff for early stage PD. When it comes to later stages, we're kind of just throwing all we can, or in some instances, we're removing all we can and just seeing what else may happen just to avoid any of that, some of the risks of those meds. So in terms of what's best, there isn't really much to say what is best. It's essentially combining a mixture of what all they've already tried, what hasn't been tried before, and how can we maintain that quality of life. And so at this stage, we're really just looking for improving quality of life. So unfortunately, there isn't a strong answer for that, but it's kind of a mixture of what hasn't been tried before. Is there any benefit at all that we could see clinically? And just maintaining whatever the caregiver goals are as well. So it's a great question.
Thank you.
Yeah, no problem.
And it looks like we had another question come in through the chat box here. So Diane asked, are you familiar with studies that have shown that lithium may be effective with Parkinson's?
Interesting. No, I'm not familiar with lithium, but I will make a note to look into that. As of now, that is not a current recommendation in terms of standards of therapy. I have seen a bit more studies with using stem cells. So essentially providing cells that develop dopamine and inserting them into the brain in some newer animal studies to essentially show regeneration of those nerves that are damaged in the brain, but also improve some safety and improve quality of life. But no, lithium, guys, if you don't know, is generally a commonly used mood stabilizer. We see it a good bit in bipolar and schizophrenia. But honestly, I have not. So I'm curious to learn more about that. So I'm going to make a note to check that out.
Can I make a comment on lithium?
Yes, please.
I have a doctor that I had just taken a class with, and you have to get a hair test to tell you if you are a person who should get who could work with they call it low dose lithium. But you shouldn't just get on it. You have to have your hair analyzed.
Interesting. I'm looking at a trial, 2020 study, essentially testing out for 6 months if low dose lithium can be helpful in Parkinson's. Looks like this is only a study of 20 people, so it's still ongoing. So we don't have any information about that there.
Yeah, I don't. Does it mention what the name of that hair test is, by the way? I don't know.
I did not look for the hair test. Yeah, I mean, lithium is great for mania. This is really intriguing. They say that lithium may have some benefits with protecting some of the nerves against neurodegenerative disorders such as Parkinson's, Alzheimer's, and even ALS. looks like they're still just finding some studies. So I'll check out this lithium hair test and see what that is too. But great questions, guys. I really did not know about that. Thank you.
And just to make everyone aware, I did put the link to Geriatric's website in the chat box here. So if any of you have very specific questions, or if you would like to start consulting with Geriatrics, I do have the information there, including the number and email address that you can get in contact to schedule an appointment. Does anyone have any other questions? Let's see, not seeing anything else coming into the chat box.
It's me again. Sorry, I missed the first like few minutes of this. I just wanted to double check. Is what type of pharmacy do you work for?
So we are a digital telehealth pharmacy. We don't dispense any medications. We strictly provide consulting services for families who are trying to manage meds and, of course, manage their loved ones' care. So we do everything virtually. No insurance, no drug products, just info, objective and fair.
Excellent. Thank you.
Mm-hmm.
And I can have your information after the webinar.
Yeah, I'll put it in the chat. I think she just did as well. So
Okay.
yeah,
Perfect.
it's all in the chat right now. Yes, ma'am.
Thank you.
Yeah.
And that's my cell phone, guys. So please just call me, text me. You have full access to me. There isn't anyone answering for me. So that's me. If you have a question, just shoot me a text and I'll happily help.
Great.
It's like Priscilla raised your hand.
Yeah. I have a question. My husband has Parkinson's and he's on medication to help raise his blood pressure whenever he stands up. He gets faint and will pass out or whatever. And so we've been on this medication now for about almost a year, but and then we went off of it for a little bit because I thought it wasn't working, but then after we weren't on it at all, I saw it was helping some. Do you I don't even know what my question is, but that a lot of the a lot of the medications that you talked about, my husband used to be on them. Right now is really only on the carbidopa, 7 pills a day. But it's still, I mean, right now he's not being able to do very much walking at all because I'm so afraid that he's going to fall because of that lightheadedness.
Mm-hmm. Yeah, no, that's a fair point. No, I mean that's it. Unfortunately, is a side effect. It can be a side effect. It can be a part of the disease progression. And so it's kind of a fine line, really, on how to manage that. I'm curious if they're using a dopamine drug to help with the blood pressure. So there's something called methyl dopa that people use to help with that. So I'm curious if they're using a dopamine drug or if they're using something else. But not necessarily it will make a difference, but that what I would do when I hear that is to try to rule out, of course, the medical cause. And if we rule that out and find it to be the progression, then now it's a matter of what's the pros of keeping it on, what's the pros of taking it off, you know?
Okay.
So that's the question you want to ask is it really still worth it now? If he's not really doing much. So that's something you may want to weigh or have a discussion about.
That's good. Thank you very much. That was helpful.
Yeah, absolutely.
Right.